زيادة.
السلام عليكم ورحمة الله. مساء الخير. Good evening, everyone. Welcome to this session on the burden of leishmaniasis during the ongoing conflict in Sudan. Leishmaniasis, particularly visceral leishmaniasis or Kala-Azar, it remains one of the most devastating neglected tropical diseases in East Africa, with Sudan carrying a substantial share of regional burden. Endemic areas such as Gaddafi State and wider regions, especially during the conflict, they have a long experience at the high levels of morbidity and mortality associated with the disease. The current conflict has created conditions that can accelerate transmission and worsen the outcome. The population displacement, the disruption of health services, food insecurity, malnutrition, and reduced access to diagnosis and treatment. Experience from previous conflicts in Sudan and neighboring South Sudan demonstrate that the war and the unrest can fuel leishmaniasis epidemics by forcing vulnerable populations into endemic areas and weaken the health system. Today's session will explore how Sudan war is influencing the epidemiology, clinical burden, and control of leishmaniasis, while highlighting the challenges faced by the affecting communities and the healthcare providers. It will also discuss priorities for surveillance, case management, and humanitarian response in this evolving crisis. Today we have two distinguished speakers. Dr. Atia Abdalla Atia. He's a prominent Sudanese physician. He's a public health expert. He's a humanitarian activist, and he widely recognized for his leadership on the Secretary General of Sudan Doctors Union. His many contributions during the wartime medicine. He remained in Khartoum during the heavy conflict, performing emergency procedures and managed trauma. And due to his bravery and refusal to abandon his patients and those who need, he's recognized as an Aurora Humanitarian Initiative luminary. He has many contributions in public health. He serves as the Sudan Country Director of Oriole Global Health, driving structural changes in the health system and medical delivery. He's also a tropical diseases expert, and he's a community healthcare expert. Thank you so much for being with us today. And the floor is yours, Dr. Atia. Sorry, we're going to start first with Dr. Mousab Siddig. He's an active researcher, but most importantly, he has been a leader at the Federal Ministry of Health. He currently serves as a director of the General Directorate of Primary Health at the Federal Ministry of Health. He played a critical role in managing healthcare distribution, epidemiology, and disease eradication efforts across the country, especially during the period of conflict and public health crisis. Thank you so much, Dr. Mousab, for being with us today. And kindly join us.
Assalamu alaikum wa rahmatullahi wa barakatuh. I hope my voice is clear. I'm talking to
Yes.
you from the field. We are in a field mission, but due to the importance of this session, I decided that we should continue and present it. And unfortunately, I have no electricity here. That's why Atia is presenting on my behalf. But it's good that the Zoom is very friendly. First of all, يعني السلام عليكم ورحمة الله تعالى وبركاته جميعا وكل عام وأنتم بخير. It's really an honor for me to address you regarding this is a very, very important topic, uh, health problem affecting many, many Sudanese. And my entrance, my first lead role inside the Federal Ministry of Health, long, long, long time ago, was Leishmaniasis coordinator. So it's always my pleasure and my honor to address audience regarding visceral leishmaniasis. So, Aki, if you could move to the next slide, please. So, I think to set the rules and for the common ground understanding, first of all, let us define what is visceral leishmaniasis. We are this presentation is going to concentrate on visceral leishmaniasis mainly. Visceral leishmaniasis is one of the neglected tropical disease. Some of you may heard the term neglected tropical disease, and I think you have dealt with so many cases of neglected tropical disease. Since Sudan is burdened by more than 15 neglected tropical disease uh, from the WHO list of the neglected tropical disease. The list is 20 plus. Sudan is burdened by more than 20 neglected tropical disease. And usually people, when they speak about neglected tropical disease, what comes to mind, uh, first of all, this is the diseases for the poorest people and marginalized population. That's why I call it neglected. But the term neglected is coming from something very different from this scope. The term neglected is coming because these diseases specifically are not well researched till now. We have a huge knowledge gap in the pathophysiology of the disease, how it comes, how it's evoke and progress inside the body. That's why they call it neglected tropical disease. It's less research. The second point, which is meant to name the neglected tropical disease as such, because the pharmaceutical companies are not very much interested to invest in developing new drugs to treat this medicine. If you look at some example of neglected tropical disease like schistosomiasis, the prazoquintil since ever is still the same, you know, drug. Soil transmitted illnesses, trachoma, onchocerciasis, even the leishmania. Now, leishmania for many, many years is just treated by the sodium gluconate. And just recently, with the efforts from all partners, especially the NDI, it is now new development of certain medicine. So the leishmania is caused by a parasite called Leishmania donovani, and is transmitted through a sandfly, the Philopetalus orientalis sandfly, the female, and the transmission is anthropomorphic. There are four main forms of leishmaniasis, and the most serious one, of course, the visceral leishmaniasis, which we will focus more on it here. The visceral leishmaniasis or calazar affects several internal organs, usually the spleen, liver, bone marrow, and it is 100% fatal if not treated. And treated, we mean a proper treatment with calazar. And the most pathognomonic, I think, features is for the visceral leishmaniasis. I remember when we were in the college, The huge splenomegaly, more than 8 centimeters, is one of the 8 differential diagnoses for the huge splenomegaly is the visceral leishmaniasis. The second form is the cutaneous leishmaniasis. This is the most common. VL is the most serious, but cutaneous leishmaniasis is the most common form. It causes skin sores and leading to disfiguring, uh, permanent scar, stigma, and some cases it will lead to disability. We have the mucocutaneous leishmaniasis, which is more present in the western part of the country. Uh, this is the most destructive form, less common form. It leads to partial or total destruction of mucosal membrane of the nose, mouth, and throat. We have a very distinguished form of leishmaniasis, which is a post-Salazar dermal leishmaniasis. It appears a lot in Sudan. Atia, if you could move to the next slide to show the pictures of the PKDL or the post-Salazar dermal leishmaniasis. It will appear as micro papula. This is like 17%. We have macula. It is around 9% of the cases, papula form of the PKDL. And we have the nodular, the most common one is 51% of the cases. So the sunfly breeding sites usually breeds in the tropical and subtropical zone. Breeding site is in Sudan are the cassia trees, Planatis forest. This is why we found it a lot in eastern part of the Sudan, in the Darif area. The favorite humidity and temperature conditions, these are the main limiting factor for the distribution of the visceral leishmaniasis sandfly vectors. We have also seasonal emergence of this sandfly. Usually it comes after the rainy season, starting the dry season, typically within February. By the end of the dry season, when we are into the rainy season, it will disappear, dramatically, the sandfly. Next. Leishmaniasis is a systemic disease. Leishmania hemastygote multiply in macrophages. VL patients are severely immunocompromised. The typical signs and symptoms are fever, weight loss, cachexia, diarrhea, hepatosplenomegaly, pancytopenia, epistaxis, anorexia, abdominal pain, which is lead to some complication due to the anemia and the decrease of the immunity in the patient will lead to malnutrition, and the patient become prone to co-infections like pneumonia, dysentery, malaria, and most seriously TB and HIV. The case definition in Sudan, according to the National Protocol 2017, is fever more than 2 weeks, hepatosplenomegaly, lymph node enlargement, and weight loss. Next. Uh, at the beginning, I think the doctor which is, presented the introduction for this session was mentioning that Sudan is burden, the highest burden in East Africa, and around 65% of the cases in East Africa is happening or taking place in Sudan. But most importantly, not that in the past there were two main foci for visceral leishmaniasis all over the globe: Southeast Asia and East Africa. And now Southeast Asia they entered the elimination phase, and some of the countries there were reaching the elimination of visceral leishmaniasis. And now the focus is, is to East Africa elimination. Sudan is shouldering 65% of the cases, in East Africa. And East Africa is shouldering 75% of the global cases. You can imagine the burden of VL in Sudan. That's why it is matter in Sudan. Next, Atia. So the graph here is showing the distribution of the VL cases per year since 2014 and going on. And you can see from the graph, there is years where the cases become very, very small in number, and the next year becomes like an outbreaks. This is usually, we saw this trend over years, and it's called the periodic phenomena of the visceral leishmaniasis cases all over the world. This picture actually, it looks like the picture in the neighboring countries in South Sudan, in Ethiopia, in Uganda, in Kenya. We have the same pattern, which is a very good topic for research, I think. So next up here. So now we will speak about what is strain protein surveillance. First of all, as a neglected tropical disease, the donor sustainability is an issue for all of us, especially with the decline funding landscape all over the world these days. Secondly, the high staff turnover. Usually, people are not settled in treating, in managing, in doing business with the neglected tropical disease. They keep changing. Also, the third point is the drug availability, insecurity and access, trust in the healthcare system, the hospital readiness, because sometimes cases need to be admitted and monitored. And when we will came to speak about the management of the visceral leishmaniasis, you will realize that many cases need to be hospitalized. And as I said, the periodic phenomena of the disease. Next. As you all know, the conflict impacted not only the visceral leishmaniasis management, but the whole health system and health services in the country. The massive displacement, people moved all over the country, and this is actually affected even the epidemiology of the visceral leishmaniasis because people went from some areas where there is no visceral leishmaniasis and settle in areas where there is a visceral leishmaniasis, so they're prone to the infection. And some people move from areas endemic by visceral leishmaniasis and then uh, move to the a new areas. So I think in the upcoming slide, we were speaking that about remapping of the visceral leishmaniasis in the country. Historically, people were talking about visceral leishmaniasis in eastern part in Gaddafi. Historically, it's not there. But now we have more than 10 states are affected by visceral leishmaniasis all over the country. So this picture shows the movement, the population movement, whether Sudanese refugees, Sudanese IDP. This is all pictures affected the epidemiology of visceral leishmaniasis. Next, Atia. Next slide, Atia, please. This is a summary of the numbers. Now we have more than 8.8 million people left their home, and we have 15,550 reported fatalities. We have more than 1,400 patients. You can see here the impact of the Sudan conflict on visceral leishmaniasis patients. As you can see, the trend of the visceral leishmaniasis is keep changing over years, but we will focus on the number of the patient in 2022, around 3,500 patients. And then when the war erupted, the number of the cases dropped dramatically to 3,000. This is not because the number of cases decreased. No, we believe that this is happening because of the weak surveillance system, under-reporting of the cases, the destruction of many health facilities, unreported cases from some state occupied by the RSF. That's why the cases were dropped. But thank you very much for the national program. I think they have done a very, very great job, the national NTDs program in 2024, where they are uh, goes for active case finding. They keep moving here and there, detecting the cases and enroll the patients in treatment. So we managed to bring the number of the cases into uh, the actual number actually of the cases. So they really, deserve an applaud. The National NGDs program. I see some of them in this webinar. So. Uh, what is the six pillar approach we are going to adopt and move forward with it? First of all, the case management. The key component for with leishmaniasis elimination is the early diagnosis and case management. We treat all the cases. This is the first pillar in the elimination. Second is strengthening the surveillance system. As you all know that if you are entering an elimination phase, it's not an aggregated data. You have to trace each patient and even the contact. As I mentioned, what have done by the national program in collaboration with the partners, the like Oriole Global, I think Atia will speak about this. They intensified the active case finding, capacity building, community engagement, and ensuring the supply chain is intact and up to the maximum. Next, Atia. So, uh, the treatment centers was 23 in 2023. We are working only in 5 states. Now, as I said, we are working in 10 states, and the number of the treatment centers increased to 43 centers. And I think the pictures here will show the centers location all over the Sudan. Next, Atia, is this my slides or you are going to continue from here?
Yeah, thank you so much, Dr. Mousab. Maybe to you. Assalamu alaikum, everyone. Eid Mubarak and evening for everyone. My name is Atia Abdalla. I'm the country director for Oriole Global Health. Allow me first to acknowledge and also to echo what Dr. Mousab mentions regarding the resilience and commitment of the Federal Ministry of Health (NTD) team who work day and night, specifically during this very difficult time during this ongoing conflict. So maybe later you can give the chance on the floor to them just to say a few words. I think without these commitments, we cannot even do something. When the people outside the country, they seeing the Sudan conflicts, some of international either website or TV, they believe that maybe all the NPD's activities stop in Sudan, specifically for the VL cases. But frankly, when the war started, at that time we came up with the new strategy to intervene so as to help those very neglected cases or very neglected Israel cases. So we cannot allow this double burden on the Israel patients, whether by the disease itself and also in ongoing conflicts. So as I mentioned, we came up with we tailor our activities to cover up all this new situation in the country. At that time, we only work in 5 states and very few centers, functioning centers, because some of them they are either destroyed or are not accessible or at least not functioning. But proudly today we can say we are working in 10 states out of 12 states and 43 centers out of 48 cities. So in the except the two Darfur, North Darfur and North and South Darfur, I think all over Sudan now is covered with the surface, with the main aim is to live normal. Uh, so I will start with some activities we managed to implement, which is the active case finding. The logic behind these interventions is, as Dr. Mousab mentioned previously, there is a very poor access to health facilities. In some areas, there is no nearby health facility, or it's not functioning at all. That's why we came up with the active case finding approach uh, with a very well-prepped car, well-trained medical doctor and lab technicians, who they have like a mobile laboratory in the car. So they're moving between villages, non-stop movement, regardless the weekend, public holiday. So they're trying to reach anyone. So they went even in the very like insecure area, or sometimes even with in the border, or sometimes in the middle of the forest to find some of those patients. So in general, I think very high number of patients they have been screened, like 1,464 patients each. So those among nomadic populations. So far we identified 547 cases among nomadic population. Those nomadic, like those special group for me, vulnerable group, they don't have access to care, and also sometimes they are very close community. So it was very difficult at the beginning to engage with those communities, because sometimes we are not allowing any foreigners, for example, to talk to them. But fortunately enough, we engaged with them and we managed to help to save life for more than 547 patients. Among those resident populations, also, we observe that there is a very high number of PKDL, specifically because of why we have a very high number of PKDL. And the short answer is those PKDL, they are interrupted treatments. So whenever they started health treatment, after 7 days, the fever subsided. So they decided to stop treatment of visceral leishmaniasis, because sometimes they achieve these drugs from black markets with a very expensive price. So in summary, I think active case finding, they save a lot of lives, and also it is give us like the hidden informations. For example, how many patients in each community died because of cholera, either those already diagnosed and they didn't get or managed to reach the near health facility, or sometimes due to stock out they are not treated, or those they have symptoms like cholera. So very high number of hidden community death. But now with this active case finding, I think we managed to reach them specifically in like more than 211 villages in 2 states. Still, this idea need to be generalized in many other states. Health promotion, as you know, Sudan, they have a VL health promotion strategy developed in 2017. So in that strategy, we have defined health education approach. For example, child-to-child approach, women-to-women, mobile theater, and so on. So far, we managed to reach during this conflict more than 47,000 people. By the way, we have very highly selective area. We just selected those areas with a high endemic or very high number of cases reported from those villages. So those numbers actually it's achieved from very, very rural villages, sometimes in the countries. And now we managed to like integrate the active case finding and health promotion together. And also we observe this is very good approach. DHIS2, as you know, data is the cornerstone for this elimination or even control of visceral leishmaniasis. That's why we came up. Previously, we have very like chronic issues with the data, either it's incomplete or sometimes like um, uh, it, it's under reports. So whenever we receive the reports previously, which is not matching the drug consumed in Sudan. That's why we need with the idea is to move from DHIS to aggregated system to DHIS to line listing. Line listing means to have all this information about the patients, all the demographic information, name, age, sex, tribe, phone numbers, diagnosis, type of diagnosis, treatments, professional diagnosis, and also the type of drugs received, and after that, 6 months follow-up. So if you allow me just to take you through this very quickly, DHIS2. Um, just a minute. So unfortunately, my network is not good. But this is like the uh, the case the cases or this DHIS2 dashboard, which give you all the informations. Unfortunately, my network is not helping me right now, but it give you all the information about the disease. And actually, it is very friendly, so you can tailor this dashboard with all information you need. For example, you just can put age, sex, tribe, and so on, which is give you everything. Also, maybe the good news here, um, our colleagues in the Federal Ministry of Health is now also thinking to have like a dashboard, public dashboard, which is, I think, uh, for all diseases, which can include all the necessary information about any diseases, can help any researcher or anyone who's looking for the validated data by Ministry of Health. It's not only about the NTDs or even installation units. Please forgive me, maybe it's not, but you can see here, for example, this is also interactive maps. It can give you, for example, how many patients per each locality, per each state. I will do my best with the network help us maybe at the end of this presentation, we can show you this dashboard. Okay, so for now, we are doing retrospective data entry for all cases treated in the country, but our dream is to move from retrospective data entry to real data monitoring, because which can help us and help the decision making. By the way, now any decision in the visceral leishmaniasis is scientific based and also based on this analyzed data. For example, if we are going to visit or to do health promotions, we will select those villages based on the Facebook, which can give us through DHIS2 system. Mobile mentor team, which is another great interventions, especially during war. So sometimes it's very difficult to invite different people from different states to be trained in one place. So it is better to go to them in their respective health facility. So to provide on-job training and also to monitoring all this, either it's laboratory or even patient card and so on. So it is a very good intervention, especially during insecurity. So to deploy those team, each team, by the way, composed of medical doctor, lab technician, and data manager who move between the health facilities. Sometimes at least they're spending 3 nights per centers, but sometimes they expand this period because, for example, in the tertiary hospital, you will find the very high number of patients or very high number of staff need training. So far, in the last 3 years, we managed to train 6,223 health staff, either medical doctor, pharmacist, the public health officer, medical assistant, different categories who's dealing with the visceral leishmaniasis patients. So also, it's not only this, but also we went for all the states, 5 states, to train the specialists, because we believe that to sustain this training, it's better to train the specialists as a TOT, so they can train the junior doctors and they can train also the medical students. Because I think the last publication from Professor Musa is there is a very low knowledge among medical students in one of the university. And unfortunately, those medical students or the newly graduated doctors, they will not be familiar with Kalazar if they, for example, they start their working in the direct system. They will miss a lot of cases. That's why I think we need to invest more on the medical students and also among those doctors. Previously, I think there is a course, orientation course for all the junior doctors, including all the main disease in Sudan, including the disease. Drug supply, as Dr. Mousab mentioned previously, is one, or actually it is the cornerstone in Sudan here. So without having enough drugs in the health facility, I think the patient, they will not decide to go to this health facility. And sometimes some of them, they go, whenever there is no drugs, they will not like advise their family and their friends to go to this health facility. So sometimes they go to the black markets. So we in Sudan, we are very transparent. We have a black market. But instead of just complaining we have a black market, we try to treat this problem. So we created a good model in Gadaris, which is a committee. It's called VL Supply Committee to fight these black markets. So include from anyone who deals with visceral leishmaniasis drugs, Ministry of Health, NMSF, Drug and Poisoning Boards, National Security, Army, Police, and so on. And also we train those colleagues about the drugs, and we give them, by the way, samples of those vials, because in any checkpoint, if they observe these drugs, they have to call this committee, which they can respond immediately. Also, we have a coordination with the neighbors countries, and maybe this drug is coming from outside the country. So we are sharing any vials found in the black markets, and we took a picture from this batch number and we share it with other countries just to make sure that these drugs is not going to the black market anymore. So we are doing a great job on this, but still, I think we need also to invest more about this. Otherwise, I think we'll be in trouble with this elimination targets, because elimination, I think the first strategy need to be implemented is early detection and treatment of visceral leishmaniasis. So early detections, we need a good test. For the treatments, also we need enough stock and safe drugs. Enough stock, that is mean all the health facilities, visceral leishmaniasis in the country, they have enough stock, so they cannot, we cannot accept waiting list for visceral leishmaniasis, wait for the drugs anymore. Also, we invest a lot, as we believe in this data, we invest a lot on the statistician who's doing the report, a monthly report. So we train them like every year. So you can see In the last May, I think we trained more than 70 people from 45 centers across 10 states. Also, we have a VL review meeting. By the way, it's annual. Despite of these situations, and maybe in the 2023, we invited only 5 states. Last year, we invited 7 states, and I think this year we have 10 states out of 12. So with the main objectives is to discuss all the achievements, challenges, mitigation, and lesson learned. And actually, some of the states, they are doing a great job, especially in the advocacy, and they did a lot of um, activities from the local bodies. So that is mean they're trying to sustain a visceral leishmaniasis activities. So there is no anymore depending on the donors, which is not sustained as Dr Mousab mentioned previously. Also, those states, when they sit together, they share their experience, which for me is a very good exercise. So this meeting was happening all through the last years, and inshallah it will continue. Another events, and also here I would like also to acknowledge the tropical disease hospital, who is the first who celebrate the first NTD. I think this was in 2022, and maybe also, I think it's 2020. Correct me, Bayam, please, later.
Yes,
So
2020.
from that, 2020. And at that time, it was sponsored by car oil company because I think maybe all the donors at that time, they are not focusing on the wearing NTD celebrations. But now it's became like a fixed event every year. And this year it was happened in Al Ubaid North Kurdufan and attended not only by federal team, but also invited team from other states. You can see here, in addition to Razan, Al-Rufai, also you can see Sahar, she's a VLNTB coordinator in Sinnar State, also Tilal from Federal Ministry of Health, and Magdi from Kassim. So also there is a representative from other states who are attending these celebrations. So I think maybe next time can be in Sinnar, I expect that after the commitments, because it is very important events, especially for advocacy. So I think in North Kordofan, His Excellency the Governor who committed to support NTDs, and I think this is one of the achievements of the NTD world. Hotline and social media, we have a mobile number and hotline, which is you can see in the right side, which is receiving call, SMS, and also WhatsApp call or messages. Sometimes we receive technical questions, and sometimes we receive queries from communities about the nearby health facility and so on. So this is like a very good, especially during the conflicts, the hotline was very good approach, which you can help the people where to go. If I have symptom like Kaladar, for example, in the Dindir area, where is the nearby health facility which I can find drugs. And that's also the same for other states. By the way, it is working 24 hours every day. Also, we did some, despite of these situations, we managed to do a supportive supervision visits. You can see here on the right side, this is a visit to the Darif Minister of Health. His Excellency Dr. Ahmed is Minister of Health in the Darif State, and also you can see Dr. Margaret, MSF NTD advisor, and also the federal team, state Minister of Health team, and also ODX team. So it was a very good advocacy to discuss with the states ongoing activities and the way forward. By the way, special thanks to Gaddarif states who took care of all VL patients, and I can say majority or more than 90% of visceral leishmaniasis were treated in Gaddarif during conflicts. So this is actually, it is increased the burden of health system in Gaddarif, and fortunately enough, the outcome was excellent despite of all these challenges. Maybe I can see also in the participant here, Dr. Margaret Dimpour. Maybe also can give a translator to this few words, please. NTD Umrakuba Clinic was set in the refugees camp in the Harif State, eastern part of Sudan, and specifically to help those refugees coming from the endemic area in Ethiopia. As Mousab mentioned previously when he showed the graph from Gaddarif, in 2022, also there is increased number of cases in Gaddarif state. But at that time, the war in Sudan is not started. But at that time, there is another war in Ethiopia, in the Tigray region. That's why we receive a lot of patients from Ethiopia who treated in Sudan. That's why the number of cases treated in Gaddarif at that time is increased. Also, I think very important to say here, in Sudan here also, I would like to thank and acknowledge all the support we received from the integrated vector management team, the Federal Ministry of Health and the state level in the 11 states. So we managed to do the first ever a national VL mapping. We can observe that even for those diseases who did their map before the war, like schistosomiasis, the last nationwide survey was 2017. But unfortunately, all the disease map after conflicts dramatically changed. So we are now receiving patients from non-endemic areas, or actually it's not known to be endemic before, indigenous cases. And also we receive cases from the states which is not known to be endemic for us. That's why at the beginning we cover all the 9 states, 9 non-endemic states. But with the Federal Ministry of Health support, even financially, we managed to implement this mapping in extra 2 states, River Nile State and Northern State. Because during the conflicts, also we receive indigenous cases from those 2 states. So the question was, do we have indigenous transmission in those non-endemic areas, not known to be endemic before? That's why we came up with this vector mapping across 11 states. And I think one of the upcoming sessions will be about vector. And also at that time, if we manage to analyze all this data, we can also show some of the preliminary results. But also my thanks goes to the field team who visit all the 11 states despite of the Eid al-Fitr holiday. And also because as you know, we cannot miss this season. That's why we work day and night hardly, starting by mid of March up till the 25th of April. So those people, they celebrate Eid al-Fitr in the field. So maybe later we can give them a very big clap for all those who involved in this VL mappings, which can help not only, by the way, Sudan, but we expect that it's going to help other neighbors countries because the wide diversity, ecological diversity in Sudan, I think is similar to many other countries, which can be also useful information to other countries. But also, Sudan is represents 65% of the East Africa VL value. So yes, despite of all this achieved, uh, uh, for me is excellent outcome, because when we consider these surrounding issues, there's a lot of challenges we face us. But for example, insecurity, every day you have to plan your day by day activity, and also to monitor the situations and to be very close coordinations with the team in the grounds. Sometimes the accessibility is not possible because some areas um, the security situation is changing day after day. Also, at that time, some of the donors they decided not to support or to continue the activities in during conflict because it's high risky for them. But fortunately enough, we have our colleagues and friends, brothers and sisters from the infants who decided to support us, and they also, despite of all these challenges, they committed to support Sudan. So on behalf of Sudan and all partners working in Sudan, and actually on behalf of VL Patient, we'd like to thank the infant and all partners who supporting us during this conflict. Other issue, for example, the turnover. Sometimes you train the people today or the staff today, and you find them tomorrow they move to another centers or decide to go to other uh, countries or other states. Supply chain also was a critical issue, but Alhamdulillah, we managed to maintain the supplies. Sometimes we relocate the drugs. But what is the lesson learned? I think after we managed to implement all these activities during conflicts, so maybe the first lesson learned is implementation of NTDs and visceral leishmaniasis during conflict is possible. And I think also other MDAs also it was implemented during conflict, so it is possible. But how it can be possible? You have to clearly coordinate with all authorities. And actually, also, we'd like to thank all those who is involved in this process and also who facilitate all the process, all the permissions, and make our life easy to reach these difficult areas. After you reach the community, you have to build this trust with the community because they hear a lot of rumors. And also you have to introduce yourself and what you are going to do and for how long. So involvement of community leaders is very essential. Otherwise, you will not be allowed to talk to the community. And that's why we manage now to engage with the nomadic populations. Strong surveillance without surveillance system, I think either it is passive through the health facility or active as we did with the active test find is very essential, which can give you information about this. Partnership. We are not alone in Sudan. We have very committed colleagues from different partners, WHO, MSF, BNDI, IND, GRID, and also the Biosystem Institute. All of them, they did a great job in Sudan. And everyone is also participated hardly to make this happen. But my thanks goes directly to federal states who left their home and left their children and decided to help those patients in the community or in the villages. Frankly, they did amazing job, amazing job. Maybe in the next presentation, we can show you some of those photos or videos from those people, Razan, Tilal, Rufai, Hiba, Jihan, and all the people who involved in this, specifically visceral leishmaniasis. Thank you so much for making this possible. Without this support, we cannot achieve anything And also my thanks goes to the higher level in the Ministry of Health, Dr. Musab, Dr. Haytham, and His Excellency Dr. Ali, the Undersecretary. I will stop here and hand it over to Dr. Musab just to continue.
Okay, thank you very much, Atia, for this very nice journey. Actually, to build on what Atia has mentioned, just last year in 2025, at the World Health Assembly in Geneva, His Excellency Dr. Haytham has endorsed the WHO elimination strategy for visceral leishmaniasis in East Africa, among many other ministries of health like South Sudan, Somalia, Kenya, and Uganda. This WHO VL elimination framework has main five pillars. They have a strategic pillars. I mentioned earlier that the first strategic pillar in the elimination is the early diagnosis and treatment. As we could find a patient early as possible for development of the complication or turn down into DKDL and treat him or her probably, this is will enhance the elimination strategy. After you can move to the next slide. The second pillar is the integrated vector management. As we all know that in Southeast Asia, they managed to eliminate visceral leishmaniasis by very strong and robust vector control management. We know that the behavior is different. The vector behavior is different in Southeast Asia from East Africa because most of the vectors in Southeast Asia are indoor vectors, so indoor spraying was very effective. Now here we have a controversial and debates. The vector is appeared in the fences in around the houses, so which is a little bit complicated the spraying and the vector management in East Africa. The third pillar is the effective surveillance. As I mentioned, while you are entering an elimination stage, it's no more an aggregate data. We have to track each patient and we have to document all it is information, including the travel history, the contacts, and everything. As Atia was mentioning before, the advocacy, mobilization, and partnership is very crucial in the elimination. And finally, the implementation and operational research. I keep advocating for this implementation research and operational research, especially in countries with many challenges like Sudan. The key regional targets by 2030 is 90% reduction in the VL burden to fewer than 1,500 cases annually, 30 days from symptoms of onset to diagnosis and treatment for 90% of the cases, 100% reduction in the VL deaths among children, 100% of the VL HIV patients initiated on ART. I will talk about this later. 100% of the BKDL patient detected and treated, less than 1% case fatality rate among primary VL patients. Why we mention the BKDL patients? You can move to the next slide, Atia. I bring the slide here again, the PKDL slides, because these PKDL patients, they are working as a reservoir. We know that PKDL is not a killer by itself, but those patients is serving in these rashes and these macules, in the lesions, they have the parasite. So whenever they are there, they are working like a reservoir for the parasite and can spread it all over the region or the area they are resided in. Another very important category of patient is the cross-infection between, or the co-infection between HIV and VL. We know that post-disease prone the patient to become an immunocompromised. Both of them, they're attacking the immunity system. So it is very important and crucial that we should treat and diagnose each VL patient, whether he has or her has an HIV infection, because even the treatment regimen will be different if he has a co-infection. So now, as a policy now in the program, and it is in the guidelines, each patient have a VL in endemic area should be tested for HIV, and a patient of HIV in endemic area of Kalazar should be tested for VL patient. In East Africa, we have a diagnosis issue because we are heavily relies on the rapid diagnostic test, which is have a very low sensitivity. We are also look for the DAG and the microscopy when we do a lymph node aspiration, and in some cases we do uh, bone marrow. The treatment now the first line is sodium stevogluconate SSG اللي هو الانتمونيوم plus the promomycin. It requires patient hospitalization, 17 days of intramuscular injection. It is effective, but we all know that the toxicity of the SSG and the high cost of the long hospitalization. We are using liposomal amphotericin B for some certain group. Now, there is a new guidelines, WHO treatment guidelines for the VL and PKDL. Regimen 1 is a miltefosine and promomycin. Miltefosine, it is an oral treatment. Promomycin is still there. Regimen 2 is miltefosine plus ampicillin. And luckily enough, last month, we were in the World Health Assembly and we witnessed the agreement, the signing of the agreement between Gilead, the company who is manufacturing the ampicillin, liposomal amphotericin B. We all know it is very, very expensive drug, but luckily enough, now it's going to be donated for the upcoming 5 years to the WHO, and it will come to the country. By the way, the miltefosine promomycin study has carried out through all East African countries. It was multi-country, and it was led by Professor Ahmad Mudawi. From here, we appreciate him. Now he's His Excellency, the Minister of Higher Education. Just to touch base on the cutaneous leishmaniasis conditions in Sudan, because I think many of us have experienced patients with cutaneous leishmaniasis. We all know it. Zubaba Ralia was. We have certain outbreaks in previous years, but now uh, in the recent years, you can see the trends of the cutaneous leishmaniasis all over years. But we still, yeah, I mean, we don't believe this is the real pictures or the real numbers of the cutaneous leishmaniasis in Sudan. We think the numbers are much, much higher. Another area of, research, I keep advocating for researches, implementation, operational, or even primary researches. Usually, we noted that cutaneous leishmaniasis is not much spread in the areas endemic by cutaneous leishmaniasis and the vice versa. Next slide, Atia. I think Atia has already mentioned how we could deal with the challenges in Sudan in his last slides. But I would like just to focus and emphasize on what should do against each of the challenges we are facing now. For example, the war displacement and insecurity. It has we have to initiate the risk assessment and reallocation for our staff, coordination, and enhance the communication. For the population displaced into endemic areas, we should scale up health promotion activities, active case finding, and integrated programs, aiming for leaving no one behind. The deterioration in the health system, we should first do the system assessment. We urge and call for donor support and collaboration, especially for neglected tropical disease, and focus on accessible, secure areas. The exodus of trained staff and the drainage we have in the country, we should continue on the capacity building of the available staff on diagnosis and management. And we are thinking now, since we are evolving and we keep updating the national guidelines and national protocol, has to be integrated in the medical school curriculum. So we don't need to going do this continuous training after graduation. It is better to come out from the universities. People are up to date according to the national updated guidelines. In stockouts and inadequate supply, we usually use redistribution between state update drug requests and advocacy for the government support. Next slide, Atia. We can't speak about visceral leishmaniasis without talking about Professor Ahmed Muhammad Al Hassan, the founder, the initiation, the leader of visceral leishmaniasis research, not only in Sudan, but all over the globe. He was a pioneer and he was putting the first steps towards controlling visceral leishmaniasis in Sudan, and he opens the door for even the treatment of visceral leishmaniasis in Sudan. May his soul rest in peace, inshallah. Thanks, Atia. Just I will finish by thanking all our partners, Oriole Global and Fund, MSF, WHO, DNDi, GREED, and of course, the main partners are researchers in Sudan, Institute of Endemic Disease, for all the efforts. So together we transform diversity into resilience, and the dedication continues. I have a special thanks to the neglected tropical disease colleagues at the Federal Ministry of Health for their dedication, for their work, and for everything they have done in the previous 3 years. Thank you, and over to
شكرا دكتور مصعب. أنا أكثر لو إنه نقم على روح راحل المقيم بس محمد ربنا يرحمه ويغفر له ويسكنه روضا من رياض الجنة، ويجعل كل ما قدموا علم ينتفع به ويجمعنا وإياه إن شاء الله في الدرس. And my thanks also goes to everyone. I will start with Federal Ministry of Health again for their dedications and also their continuous support. I think we cannot do anything without their support. And also to State Minister of Health and also the health focal base in each locality. All of them, thank you so much. And also a special thanks to the Minister of Health, Dr. Ahmed Al for all his initiatives to support visceral leishmaniasis specifically. And now the Minister of Health is planning to do the first ever visceral leishmaniasis conference in Sudan, which they're trying to implement those eliminations goals. So inshallah, you will hear about it more and more, and I think this is going to be one of the upcoming topics about we can talk about how we can reach the elimination. Also, my thanks to our colleagues to the infant led by Infant and Cabron for their supports. Actually, continuous supports. All these field activities and drugs supported by them. My colleagues in the Oriole Global Health, either in the country, in the regional office, in the HQ, and also all other partners who is not mentioned in this slide. Thank you so much. Our colleagues in MSF, and I will start by MSF Holland. And also I think we can give a chance to Dr. Margaret later. And also MSF Switzerland. So they, and by the way, MSF Holland, they started supporting visceral leishmaniasis in Sudan since 1995 in Qura village in the parish 1995. Also, my thanks goes to ECB, and also I can see one of my colleagues, Imam Bremen, maybe also can use a chance for their support in this matter, ongoing visceral leishmaniasis. Our colleagues in the DNDi for negative disease initiatives, Dr. Channels and his colleagues, thank you so much. Our also thanks goes to WHO, Dr. Sarab in HQ, Dr. Mona and her team, Khalid Saror and his team in the country office. Thank you so much. Without all this support, we cannot also reach all these colleagues. Professor Maawiya and his team in the bioscience research, Professor Ahmed Mudawi in the Institute of Endemic Disease, University of Khartoum, Professor Jamal Khalid, Dr. Abdullah from the Paris Regional Institute for Endemic Disease, and everyone who involved in the Fedral Leishmaniasis. Thank you so much. And actually, special thanks for those VL patients who sometimes they are so patient with us, and also they are so cooperative with us. That's why we reach a very good outcome in terms of the drugs outcome or even the coverage of the health of the field activities. And actually also thanks to all our families and children who also keep patients. I think they miss uh, us during this conflict because now Dr. Mousab is talking to us from the field, but also previously, sometimes or one of the presentation previous, it was also presented from Salala area. So special thanks to Professor Dia and his team for their support. Uh, Deeply sorry for anyone who I missed to mention here. Thank you so much. And all of us together, inshallah, we can work hand in hand to control, eliminate, and eradicate not only NTDs, not only visceral leishmaniasis, but all NTDs. Organizer, if I can request serious chance go to Dr. Margaret from NSF, and then you can open the floor. شكرا جزيلا. Thank you so much.
Thank you so much for joining us today, and thank you for the insightful and very informative presentation, Dr. Mousab, Dr. Atia. We appreciate your time. Dr. Margaret, welcome on board, and the floor is yours, please.
Excuse me, did you mean me?
Yes, Dr. Margaret.
Oh, thank you so much. Thank you so much, Dr. Mousab and Dr. Atia, to give me the floor for a moment. I've followed this presentation with a lot of interest. I have worked with both of you for many, many years, and as a representative of MSF, I can say that we are fully committed to support NTD and especially Kala-Azar and also snakebite treatment in Sudan, and also to work hard with you to achieve the goal of eliminating this disease that is really affecting the very, very poorest of the poor people. So thank you so much. And I hope to attend the next presentations as well.
Thank you, Dr. Margaret, and thanks for all the team in the field for their heroic work, which without we would be in a lot of trouble. So thank you for your ongoing effort. Please welcome with me Professor Ahmed Ajab al-Dor. He's a distinguished medical professional and researcher. He's a consultant pathologist at Kurdistan University in Al Ubayyid. Thanks for all the honorable guests today, all the team, Dr. Rafai, Dr. Razan, Professor Muawiyah, and all the honorable guests. Also, thanks, Prof. Hamid Asawi, for joining us today. Talal, I think now we open the discussion for the floor. If you have any questions, please feel free to raise your hands. But I'm going to start with a question from my side. Some of our colleagues in different states reported that they noticed a visceral leishmaniasis cases without any history of traveling. I think it's all contributed to the IDPs. But what about the vector? Is it now transmitting to non-endemic areas?
So Could we reply one by one, or we should take a group of questions?
I think one by one is better, just to cover as we go.
Okay, I can start, and Atia may complement all the program members who are here. Raza, Abdullah, Rufai, whoever want to come in, please, after my initial response. Of course, with what's happening in Sudan and displaced population moving from here to there, we found that now the vector is almost everywhere in Sudan. And the parasite comes with the people moving from here and there. That's why it was the trigger for us to initiate this national VL mapping, where we are going. The result, by the way, it's not out yet, but we are expecting it by this month. So it will show clearly where the parasite is available in the country. And of course, with this population, it's highly expected to have a new foci for visceral leishmaniasis. In the past, people just focus on East Sudan, the Gadarif area, but few years later, we found that visceral leishmaniasis in Darfur, in all Darfur states, and recently we have it in Khartoum, in Jazeera, in everywhere. So this is the short answer. I don't know if Atiya, if you have another comments, please.
Yeah, I think this is actually what we say. And I would also agree with Musab. We need more research to understand this. So what we observe in Badar specifically is those IDPs, they came from non-endemic area with a naive immunity, and they settle in very high endemic areas. That's why they develop a disease very fast. And also sometimes they have very serious complications. It's not like the patient who reported from Gadaris, because at least those patients from Gadaris, they have immunity against Canada. But sometimes, especially this is what we observe during conflict. I think history of troubles, it is not working in Sudan anymore. That's why even it was in the last national protocol, 2014. At that time, in the case definition, uh, it was fever more than 2 weeks, hepatosplenomegaly, lymphadenopathy, weight loss, history of travel to endemic areas after exclude malaria. Now we observe that no need to exclude malaria, because it's already, you can have a calazar and you have co-infection of malaria at the same time. Additionally, and I think now what we observe during this conflict, we got patients from non-area or non-state or states not known to be endemic. That is mean maybe there is already endogenous transmission in these states. But as I mentioned, is now we have a VL mappings, which is going to prove that did we have a vector in all those states or not. And I think very soon, inshallah, we'll come back to you with this preliminary result, which can actually highlight a lot of side which is obscure in the VL transmission. Allow me also to thanks again my colleagues, Dr. Silwan, Dr. Rania, Ms. Riham, Dr. Muhammad Al-Hadi, and everyone who involved in this um, journey. Thank you so much. Over.
Thank you. Professor Ahmed Ajab Al-Dor, is there any trends you've noticed in Al-Ubayd or Kordofan region? Welcome among us. Okay, Dr. Amal, you can unmute yourself.
السلام عليكم ورحمة الله، مساء الخير جميعا. شكرا جزيلا دكتور مصعب، شكرا دكتور عطية. وزي ما قال دكتور عطية، ما في زول بيكون يشتغل في الليشمانيا ايشوز وما بكون عارف رزان، ولا بكون عارف رفاعي، ولا بكون عارف جيهان. وأنا متأكدة في أزرس كثيرين، يعني جنود مجهولين في الفيلد شغالين. فتانك يو فيري ماتش. يعني إنه they prove their dedication في الكونفليكت وفي البيس تايم. أنا سؤالي لدكتور مصعب إنه what about السبراينج أو الكوست effectiveness بتاعت السبراينج from البرسبكتيف بتاعت البروجرام، الكنترول بروجرام. What do you think? Is it cost effective مثلا زي الملاريا السبراينج outdoors، خاصة زي ما انت ذكرت انه البيهيفير بتاع الساند فلاي not like India or Southeast Asia انه هي mostly outdoors. Can we يعني is it a challenge انه to eliminate it by spraying؟ الحاجة الثانية القصة بتاعت الأكاشيا بيلت. what about this issue؟ يعني we can never get rid of الأكاشيا أو شجر الخشب، لأنه هي مهمة جدا عندنا في السودان، يعني as an ecosystem as an export as حاجات كثيرة. and so we can never get rid of the sandfly as إنه هي الهابيتات بتاعها. so what do you think on this issue؟ and thank you مرة ثانية. شكرا.
Can I come in?
Yes, please. Yes.
Thank you very much, Dr. Amal. يعني good to hear from you after this very, very long period. You know, Dr. Amal is one of the heroes and the fighters against VL since a very, very long time. Very good to see you today and hear from you. Thank you very much for raising these very important questions regarding the vector control, the vector efficacy, efficiency uh, in Sudan. As you truly mentioned that the behavior is not the same. That's why the IRS uh, is very effective in Southeast Asia, and that brought the elimination to its target very, very quickly. We have challenges here. There are some studies have done by Professor Bian Naim, I think in 2019, 2018, I'm not sure about outdoor spraying in the fence. It shows some efficacy, good efficacy result around it. Of course, it's not to the optimum and what people look at it, but it has a role in reducing the sand flies around the houses. There is another measures were proposed by Professor via that studies impregnated clothes, wearing long sleeves, and doing several vector control measurement. You are truly mentioning that we cannot get rid of the acacia trees and we cannot spray all the acacia trees. But now with endorsing the elimination strategy, WHO elimination strategy, our main focus is not to get rid of each sandfly in Sudan. Our main focus is to eliminate the parasite from the blood of the Sudanese people. At that time, when even if we have the sand flies is there, but there is no parasite in the people, I think we are going to an elimination with a good window. We'll give the floor also to Atia if he would like to comment on this.
Dr. Atia, any comments? Okay. Dr. Iman Brema, we'll get back to you. I think we have few questions in the chat box. We'll go through them quickly. The question for you is, what are the plans to reduce the spread of the disease through arrivals from Ethiopia?
We had a cross-border meeting with the Ethiopian colleagues, and this question was came out from them because now even they think with the while the war was in 2023, 2024 around Gadaref, a lot of Sudanese people crossed the border towards uh, Ethiopia, towards Ethiopia there, and they were afraid that we are going to spread the disease to Ethiopia. But thanks to God and for all the efforts from the army, the improvement of the situation, now we thought back about what is going to happen for the cases coming from the Ethiopia. I think in one of the slides, Atia has mentioned that very clearly. We targeted the IDPs, the refugees, sorry, camps specifically in Rakuba, where we have health promotion stations. We had the early diagnosis there for all of the patients and proper treatment for all of them. I remember that one of the health promotion campaigns done in these refugees camps was written in Tigray or Amhara language, so as we are targeting them early as possible to diagnose and treat each of these uh, patients. Over.
Thank you.
Dr. Mousab, excuse me, can I just jump in? I think cross-border issue is very critical. It's not only Ethiopia, by the way. We have Eritrea, we have Chad, we have South Sudan, and previously, I think Uganda, Kenya, and so on. And even in the, I think 2020, and Rayan can also correct me, there's more than 37 patients who came from Chad and treated in the tropical disease hospital from the mining area. So we need to strengthen this collaboration with the countries, neighbor countries, because we cannot fight Palazar in the border without coordinating. Other issue which is very important as well is regarding it is not, in Sudan here, it's not only the refugees and the IDPs. We have other vulnerable groups. We have the seasonal workers who's coming from other countries or even from other states here. We have seasonal workers who going to Gadaref during the agriculture or the harvesting time, mainly coming from on non-endemic area. That's why those they are developing Salazar very seriously. As Dr. Mousab mentions, we have Leave No One Behind project to reach all of them. And now, fortunately enough, we started with the nomadic populations, and those nomads, they cross the border. So they started from Gadaref, crossing Sinnar, Blue Nile, South Sudan, and some of them, they crossed to Darfur, and from Darfur to Chad, even up till Cameroon, and they return back. So this is very important. We need the countries together. By the way, Southeast Asia, they didn't manage to reach the elimination goals unless the three countries, Nepal, Bangladesh, and India, they sit together and they sign MOU between the three Ministers of Health. After that, they managed to achieve those goals. So we cannot work in silos. That's we are believing in coordinations. I think one of the questions also regarding the new guidelines. As Dr. Mousab mentioned previously, now WHO is expected to release the new guidelines, which is multipurine bromomycin instead of bromomycin sodium stibuleucrate. But the other, for example, for co-infection is already, I think, it's released, which is multipurine ambison. I think also maybe in the upcoming periods, we can also come back after we starting updating our protocol based on the WHO guidelines. So just now we are waiting for WHO guidelines to be released, and after that we can start updating our national protocol, and also we can also continue on the training of health cadre, and so on. Not to forget those people who's working in the data. Without this data, we cannot even reach elimination goal. Now they are supporting us a lot, and also they are trying their best. Now we are, I think, the most active program in East Africa who has active DHIS2 line listing, which can help us not also to reach the elimination goal, but inshallah also to reach eradications. Thanks. Over.
Thank you so much. Dr. Ayman Brema, feel free to unmute yourself. دكتورة إيمان.
السلام عليكم ومساء الخير على الجميع. Thank you for the nice information or informative information from Dr. Mousab and Dr. Atia. I just want to comment on this acacia, the question from Dr. Amal, because acacia, as I'm working in acacia, it is enhance the transmission of the parasite because the vector takes the sugar from the acacia, different acacia, in this for us is a tropical and dry land, and as I am working on it because they cannot live without taking sugar. Yes, I'm trying to find a solution or to use it as a control for this vector. That is why I think in Sudan, because it is most dominant, it is acacia, even here in Kenya and Ethiopia. Thank you very much.
Thank you so much, Dr. Iman, for explaining. Professor Hamid Al-Sawi, do you have any comments? Please feel free to unmute yourself.
السلام عليكم ورحمة الله تعالى وبركاته. أسعد الله أوقاتكم جميعا بكل خير. الحقيقة الواحد يعني فخور ومبسوط بهذه الكوكبة من أبناء الوطن، بيعملوا في واحد من أصعب يعني الأمراض اللي موجودة في السودان متوطنة، ويعني بتسبب كثير من المورتاليتيز والموربيديتيز، وعيق حتى يعني في نمو وتطور البلد يعني. وده يعني جهود ما هي جهود بسيطة، يعني جهود الإليمينيشن والإراديكيشن دي ما هي جهود بسيطة، وما حتكون إلا تتضافر فيها كثير من الجهات كلها كاملة متكاملة. وآي ثينك إن شاء الله بإذن الله طالما هم بدوا في الطريق فحيمشوا. الحقيقة الواحد استمتع بالمحاضرة يعني قيمة جدا، وبرزنتيشن راقي. دكتور عطية، دكتور مصعب، وكل المتواجدين، مجموعة من المعلومات الضارة والقنية، يعني زادت في معرفة الناس وزادت في معرفة الواحد يعني. وشكرا كثير لكم، إنه ربنا يوفقكم ويجعل طريقكم دائما يعني طريق خير، وطريق إنه ييسر لكم كل الأمر إن شاء الله، تصلوا للتارجتس بتاعتكم بإذن الله تعالى. ألف شكر، ألف شكر لكم، وألف شكر للمنظمين. شكرا كثير دكتورة يعني ظلال على الدعوة، وجزاكم الله كل خير. شكرا لكم.
Shukran, Prof. Hamid Al-Sawi, for joining us today. Thank you for your time. I think we have few more questions in the chat box. What are the strategies have proven most effective in reducing Leishmaniasis transmission in humanitarian settings? And the other question, how can humanitarian organizations better integrate Leishmaniasis control into primary healthcare services? Good questions.
To allow me to jump in here.
Yes, please. تصميم شغلك.
Okay, thank you very much, actually, for all the speakers and all the comments and all the questions. Really appreciate this. I'm very happy to see the enthusiasm about the visual leishmaniasis elimination in Sudan. And I'm really urge each member here, each person here, the professors, your efforts is really is going to complement what we are doing now. The research is doing by Ms. Prema, the research is by the professors here. It's really going to help us and support us a lot in the elimination target. Regarding the last question, what is from my point of view and my humble experience in the leishmaniasis control, the most efficient uh, strategy to eliminate leishmaniasis is early diagnosis and proper treatment, not only starting a treatment and then stop it afterward. As it is stated very clearly in the elimination roadmap, the first pillar is early diagnosis and early treatment. That's why we initiated this mobile teams, active case findings, looking for the patient before even showing up in the hospital, finding the patient early as possible and treatment promptly. This is will help a lot, and it is really the strongest strategy in the elimination target. How the humanitarian actors could help in integrating the DL treatment and diagnosis into the primary health care. I think this has already happened. Now we are working with many humanitarian and NGOs, after all, international NGOs, the national NGOs. Now they are working with us. Just Visual Leishmaniasis is completely supported by Infant Oriole Global WHO, and they are very happy. These 43 centers now we are working on, they are not solely VL centers. These centers are serving another PHC programs and another PHC service. So it is automatically embedded in the PHC service package in the endemic area. What we can do more is to expand these services. As we can see now from the discussion and the presentation now, leishmaniasis is all over the book. What we are going to do is to increase the capability of the people to suspect and diagnose leishmania, just to refer them to the treatment center as early as possible. And I think Dr. Atia will agree with me that we are going to expand after the result of the TL mapping came out in early diagnosis and not initiating a treatment center, but a referral pathway favorable and friendly to the patient. Thank you, and over to you, Atia, if you have.
Thank you so much. Thank you so much, Dr. Mousab. I think decentralization of services is one of the components to reach eliminations. Dr. Margaret and MSF team, they have a huge experience in the conflicts, and actually they published maybe last 2 weeks a paper about how to implement NDTs during conflict. So, and also here in Sudan, during the war started in South Sudan, we started implementation of decentralization sites just for diagnosis and treatment and referral. As we know, the visual leishmaniasis treatment, it must be in the hospital level because we are using very toxic drugs which need supervision. But at least now, we can have these decentralization sites to detect, test, and refer any suspected patient to nearby health facility. Frankly speaking, this need like a good rapid diagnostic test. Previously, we are using RK39 Biorad, which is a very good sensitivity and specificity. But now we are using another RK39, which is RK39 in BIOS, which has very low sensitivity. That's why we miss a lot of cases. This early detection and management of cases, I think it can through it we can actually we can achieve those WHO goals, but also it can decrease the mortality and morbidities. Because usually when we receive a late presentation patient, sometimes they came with renal failure, hepatic impairments, and so on, and sometimes even heart failure. So we need to work hardly to expand these services. And by the way, the elimination goals asked for at least one health facility or one treatment center by endemic locality. So each endemic locality, at least we need to have one health facility, but also to have a decentralization sites in the countrysides, in those villages, to make sure all those patients is detected and referred quickly, so as we can decrease the time from symptom to treatments so as to be less than 30 days based on WHO goals. Over.
Thank you so much for the elaboration. There's a comment from Dr. Hanan. She's saying, in case we launch elimination, we should consider border issues, the cross-border issues, and the population movement. I think this point is covered. Another question is from Dr. Loy. Are there biological control efforts targeting the sandfly, which is a vector, such as fungi or other novel approaches? And how effective are they compared to traditional vector control methods? Good question.
It's an excellent question. It's not just a good questions, and it really shows that there are some people are following very closely because now the control effort for some fly using into pathogenic fungi like the Varia baciana or Metrhizium and Sublia. It's only confined to the laboratory findings. Still, it's not rolled out as a very effective control measures. It's still under study. As far as I know, I have not read or heard about a country who is, adopted the entomological control for the sandfly as a vector control measures. But the results in the labs are showing a very, very promising result. Just people now are thinking about the biohazards and what could happen after this. Especially, we are not going to enter to a cobra effect when we're introducing a fungi, and then we will end up by another big complication or problems. And I think this is a very good topic. If I may propose for people at the tropical hospital to be the questions or the topic for the next webinar, since we are all looking for the innovations, we could invite the right people and speak about this. It's really something to think about and to see how it's to push it forward. Since Sudan was a very pioneer in the biological control for different vectors like malaria and other, and now we are thinking also about the vector control using biological methods and gene techniques in controlling dengue and other related tropical diseases. Over.
Thank you so much. There's another excellent question from Dr. Muawiya Ahmed Al-Badri. Thank you so much for joining us today. He's a prominent academic, medical researcher, and lecturer specialized in microbiology and medical parasitology and medical education as well. Feel free to unmute yourself, Dr. Muawiya, and ask directly. Otherwise, we're happy to ask the question on your behalf.
Assalamu alaikum.
Wa alaikum assalam. Thanks for joining us.
Thank you for this nice presentation. It's really an updating for me because I have a long time since deal with these topics. My information seem old, but I want to update it because you said that there is imported cases from Ethiopia, and there is in Ethiopia there is a diffuse cutaneous leishmaniasis, as I think Leishmania acidic or something like this. And I read earlier that there is a cases of diffuse cutaneous leishmaniasis in Sudan, maybe sporadic or imported. Are there is any update about this condition in Sudan? Um, the other issue is the reservoir. I think you are concentrating on the or your are emphasis on the vector. But what about the reservoir? Are all cases are anthropogenic? There is no role for reservoir in this case. And maybe the third question about RK37, I think. What is its role in the control? Sorry for interrupting you.
Thank you very much, Dr. Maawi. Actually, you are not interrupting us. You are enriching the discussion. Thank you very much for joining and for raising very important questions. We are very happy to see you here, and we hope you are going to continue with us towards the elimination journey. Regarding the first question concerning about the mucocutaneous leishmaniasis, up to my knowledge and to the reports I have seen, we had never seen a mucocutaneous leishmaniasis imported from Ethiopia. But surprisingly, we have a mucocutaneous, diffuse mucocutaneous leishmaniasis in eastern part of the Sudan, in the western part, sorry, of the Sudan. We reported many cases before the war from western part in that poor area specifically. We have several cases there. But Atia may correct me because he is much aware about the data and the cases since he's following very close the DHIS line listing. Regarding the second question about the reservoir, up to date now, Sudan epidemic is classified as anthropoid disease. There is no role for reservoir beside the BKDL. We are treating the BKDL as a reservoir. That's why we are targeting and intensifying efforts towards treating all BKDL patients because they are the main reservoir. In the past, I remember very well when we started VL control program in Sudan, there was a huge campaign in the Darif targeting all the canis dogs and everything because as a part of the VL control strategy, but it has been proven over time there has no role in a reservoir in Sudan. Sudan has not canis are not a reservoir for the VL. But I think it's also an area for research need to be addressed. I will leave the RK issues to Atia to respond to it. Over to Atia.
Thank you so much, Dr. Mousab. Thank you so much, Dr. Maawi. I think RK39, frankly speaking, we have an issue with the RK39 inverse, which has very low sensitivity and specificity. This cannot help us to reach elimination goals. I think now also we are trying to have a DAT, direct agglutination test, which can be complementary tests for RK39. Because according to diagnostic algorithm, sometimes if you have a positive RK39, go for treatment. But if you have a negative and still suspected case, you have to repeat the test. So without having a good rapid diagnostic test, I think these will be in trouble in terms of early detection and treatments. I think WHO right now, they are evaluating many rapid tests, which can be, I think the result can help us, which can be used in Sudan. Because, by the way, more than 87% of our cases treated in the rural hospitals. But sometimes even in the state capitals or in this tertiary hospital, you have a luxury of doing bone marrow aspirations and also other tests. But in the field, there is nothing to do. So you have to have like expert lab technician who can do a bone marrow aspiration, lymph node, or even splenic aspiration under the guide of the medical doctor. Uh, I think also regarding the dogs or the reservoir, also I agree with Musa because still we don't have this published data about the dogs. But as far as I know, Dr. Hanan from Gadarif University, she did unpublished paper, which reveals that there is no role of dogs in the transmission of visceral leishmaniasis. Although in other countries, yes, dogs is a part of this transmission. Regarding CL and MCL, I think if I start talking about CL and MCL, I think I need another 30 minutes, which is not possible because I think we only have remaining 7 minutes. But I would suggest for the organizer if you can have special um, session for other forms of visual leishmaniasis, specifically CL, MCL, BKD, because we have a lot of things to say. Just quick answer, Dr. Muawiyah. Previously, we are talking about in Sudan, we have Leishmania tropic, which is self-limited within 6 months. No need for treatments. The lesion can be healed or like within 6 months without any treatments. We observe a lot of leishmania caused by other vectors. And we have, for example, some of the patients in South Darfur, which they have a multi-lesions, sometimes more than 80 lesions in the kidneys, 80 CL lesions. I think I'm not going to talk about, but again, I will emphasize my point is let us have a special session about the CL because even during conflicts, you hear a lot of rumors about the CLs. For example, there's a rumor of outbreak in Rufa'a in Al Jazeera state, and I think on Brombita in the Darfur or Kordofan, a lot of areas. So the question will be which type of CL? Allow me to stop here, but let us continue in other session. Thank you.
Thank you. It's much appreciated. دكتورة ريان تنجة تفضلي.
السلام عليكم ورحمة الله. مساء الخير عليكم. أنا دكتور ريان علي تنجة، أخصائية الباطنية، ماجستير طب المناطق الحارة والأمراض المعدية. أول حاجة داير أرد على دكتور معاوية. في case has been published by دكتور عبد السلام and دكتور معاوية مختار عن patient with diffuse cutaneous leishmaniasis كانت admitted to the hospital for several times, received many kinds of treatment with no with mild improvement. This case was documented and published. I will try to find the link and share it with you. Second thing I want to say that from the start of this academic club, we are waiting for this series of Leishmaniasis lectures. We have done more than 40 lectures, but we are very excited about these sessions, and this is a great start with Dr. Atia, an expert in Leishmaniasis. Whenever you said visceral Leishmaniasis, his name come with Dr. Mousab. They gave us a very insightful and very informative presentation. So the words cannot thank them. And we are so happy to have them today and in the upcoming sessions, inshallah. I would like also to welcome all the colleagues and professors that joined us in the session. Prof. Ajab Al-Dor, Prof. Sherfi, he is an expert in mucosal leishmaniasis, and we will have this session, mucosal leishmaniasis, because it is a very neglected and hidden part of leishmaniasis. We will see that data about it, and definitely we will have another session about cutaneous leishmaniasis, despite that we've done it before. So thank you very much, and you are highly welcomed in the upcoming sessions, inshallah.
Thank you, Rayan, for elaboration. Okay, we have one last question قبل ما نختم. With regards to sodium stibogluconate toxicity in the treatment centers, are equipped to treat severe toxicity, or there is a referral system to one place? Followed by, is there collaboration between the NDT program and Pharmacovigilance Center at the NMPB? I don't know what that stands for. سؤال from Asma Tuhami.
This is National Medical Medicine Symposium Board. I know
Sweet.
this question could not come from an ordinary audience. Dr. Asma is an expert in the public health management. She's an expert in malaria management, and I'm very proud to say that I have been trained on her hand on the drug efficacy study on the anti-malarial efficacy. And I become a consultant for anti-malarial efficacy studies because of Dr. Asma. And that's why she brought a very, very important and a really an eye-opener questions for the people in the program regarding the SSD toxicity. In the treatments, forms, we have this severe adverse events site to be documented and reported. And even I think Atia, it is there in the DHIS too, because I think we had a discussion around the importance of reporting the severe adverse event, especially for SSD. And I hope that when we are adopting the new regimen, we are getting rid of the SSD toxicity. Regarding the collaboration between the NTD program and the NMPD, it's really an eye opener for us. We need to strengthen the collaboration and the coordination between the national NTDs program and the NMPD. Thank you, and over to you.
I share my screen. Can you see my screen?
Yes, we can. Thank you, Dr. Asma, for
Yeah.
that.
Yeah, thank you so much, Dr. Asma. Actually, thank you so much, Dr. Asma. Actually, also I decided to share this, which is a visceral leishmaniasis term. And it is not like a request, but I kindly request all of you, all the clinicians who are involved in visceral leishmaniasis, please fill this card. Now previously it was yellow, then we changed to green, and now we have a blue card, which now we are changing the card because we move for eliminations. In fact, we need all this information in this. Please spare like 5 minutes to fill these patients. We are trying our best to get supply to the country, but unfortunately, without proper documentations, we cannot prove Sudan they have this number of cases. Now, according to WHO, they just give us drugs for average of 4,000 patients per year. But unfortunately, we engage in the stockouts because we are treating patients, but we are not recording them. So please, this patient file, even if there is a hospital patient records, also please fill these patients. Without these information, we cannot reach even the control. Because specifically, for example, previously, Mustapha Muhammad Al-Amin Pediatric Hospital, who discovered there is outbreak in White Nile State, in Umrimta locality, because all the patients at that time, they came from that area to be treated in Khartoum. So without proper history and examination for the patient, we cannot reach to this area and to discover this. A lot of cases came from Umrimta. Back to you, Dr. Asma, if you can see here, it is include everything. Anything more than 91 indicators, which can help us to reach the elimination goal. But also, we have, although those drugs, especially SSGBM, it was underwent for all the clinical trials and also the pharmacovigilance, but still we have a pharmacovigilance report in this format. So whenever we have reported any SAE, severe adverse event, please contact, from the health facility to contact the federal level, or first the state level, and then the federal level. The federal level, they will contact drug and poisoning boards, and also sometimes to organize like an area meeting to discover why. Previously, we received some of those severe adverse events, but we discovered, for example, with there's a lot of complaint. Ambisome, it is not effective for the treatment of visceral leishmaniasis, which is surprising for us. So we made a quick assessment to understand why Ambisome it is not effective in this only one health facility, by the way, in only one state. But we discovered that they mix Ambisome with Normas. So for sure, the result it will be zero. So that means we need to adhere to the protocol, and that's why now we have ongoing training to sustain the knowledge among all the health cadres who involved in this. But I will add my voice, all of us, to work hardly. Now we have a new guidelines, it's coming very soon, multifocin bromycin. So please, all of us, let us collaborate together and to report any SAE, and also to make efficient pharmacovigilance at health facilities. Shukran.
Thank you, Dr. Asma, for bringing this very important point and highlighting the importance of pharmacovigilance. And thanks to Dr. Atia for answering. Okay, I know we're out of time, but we have one very last question regarding the use of RK39 in endemic areas with high infectivity of VL. How do we deal with false positive results, and what are the other options? Question is from Dr. Abdalla Ibrahim.
Mousab, you want to go first? Okay, so I can jump here, and then Dr. Mousab can also come later. As I mentioned, the current RK39 inverse, which is not a good quality, we noticed that. But in general, regarding the test of all suspected patients, we need to follow the national protocol. In fact, this RK39 it should be tested for suspected patients. If the patient is not fulfilling the case definition, fever more than 2 weeks, hepatosplenomegaly, lymphadenopathy, and weight loss, it should not be tested for RK39. Because we had one of the study in the Darif state, case control study, and we did screening for some of the villages, and we got some of those patients who were positive, but it's not having any symptoms. So if we start to treat any patients just because of having positive, for me it is false positive RK39, I think we'll put this patient in the high risk of using SSG, for example. I kindly request all those people who deal with Calazar, please don't use RK39 for screening. RK39 is just for confirming the suspected VL patients, which is fever more than weeks, hepatosplenomegaly, and weight loss. Shukran jazeelan.
And I'm really sorry, but last question, it's a yes, no question. الداشبورد فاتح؟
The dashboard is now, it's not open for everyone, but our colleagues in DHIS2, they have a new board, which is called portal for all entities. The same dashboard, if you remember, during COVID-19, there is a dashboard which is a public use, having all the information. I think for now it is not public because we are trying to hide some of this information, for example, patient name and so on. But inshallah, we'll make sure that this public dashboard or portal. It will be open for everyone, at least with the basic information. Before having that dashboard, and I think our colleagues in the Ministry of Health, they will be very happy to help anyone with any information they need. Shukran jazilan for all of you for organizing these events. Thank you so much for everyone who make it and also join us for the last 2 hours. Shukran jazilan. And again, thank you so much for everyone who involved in this journey and trying to help the Sudanese people and also the Sudanese VL patients during this conflict. Shukran jazilan. Assalamu alaikum.
Thank you very
شكرا.
much, Atia. Actually, I jumped in directly, so I'm sorry for that. But I really want to thank all the attendees here in this very, very nice session. And I am urging all of you, clinicians, researchers, vector control managers, professors, please join us in the journey of eliminating visceral leishmaniasis in Sudan. It's really a challenge. And people outside the country, they are really impressed about what we are doing in the country, and they saw that we cannot achieve it in our context. But we took the challenge, and I am very confident. I'm very proud about the level of discussion here, the level of the scientific arguments mentioned here in this forum. We are going to achieve it. And I'm really urging all of you and thank you very much for the Tropical Hospital for organizing this. And I'm calling another session to expand and to discuss more about the various aspects of leishmaniasis and various aspects of visceral leishmaniasis or leishmaniasis in general in the country. I'm sure that all of you are very, very busy, but we can take the opportunity to get your valuable insight and inputs regarding the elimination of leishmaniasis from Sudan and elimination of all neglected tropical disease. Thank you very much for the Tropical Hospital scientific forum, for this very good organization. And I will jump to the next meeting, inshallah. Okay.
We much appreciate your time, your experience, and your heroic work in the field. Would like to say لن تسيروا وحدكم. العلم والمعرفة ما استطعنا. قاعد نحاول قدر ما نقدر إنه نوصل المعلومة للناس to give updated picture of what's happening. دي أول محاضرة في الليشمانياسيس، وأكيد ما آخر محاضرة. محاضرتنا الجاية حتكون vector control followed by clinical presentation and diagnosis of VL, followed by management of VL, followed by VL with co-infections and special populations, pregnancy, pediatrics, and immunocompromised patient, followed by mucosal leishmaniasis, and finally research in leishmaniasis. محتاجين 200 session عشان نغطي الليشمانياسيس. But we're just trying to touch base and highlight and address the burden and the importance of the disease. We appreciate all the audience for being here, for enriching our discussion today. We do appreciate كل الناس اللويال للنادي الأكاديمي. We're not going to stop إن شاء الله. Over to you, سارة طيب. ختام.
Thank you so much, my partner in crime. I think that was a great kickoff to our Leishmaniasis series. It is one of the series that personally I was very excited for, because I remember when I was a house officer in my shift of internal medicine, the first patient I've ever encountered and I've been looking after was a patient of visceral leishmaniasis. So this session really means a lot to me, as well as when I started my rotation in internal medicine. Also, I have done my first shift in Al-Gadarif. So I have been in close contact with cases of visceral leishmaniasis. I have seen it in a very wide spectrum, leishmaniasis, visceral leishmaniasis, cutaneous leishmaniasis with co-infections. I've seen it all. It is really something that needs to be discussed as much as possible. People need to know more about it, about the disease, the distribution, the management, the diagnosis, the clinical definition of cases. So this series is going to be something I'm really, really, really waiting for. Thank you so much for our esteemed guests, all those who attended the sessions, and a very special thank you to our amazing speakers today, Dr. Mousab and Dr. Atia. Thank you so much for your amazing presentations, for the amazing discussion, and all the wonderful information that you've shared with us today. And also a round of applause to my colleagues in our Tropical Academic team for the amazing, as usual, hosting for the session and the preparation and everything. We will continue, of course, inshallah, in our future sessions, as Zalal just mentioned, and we'll be exploring more and more about leishmaniasis. We are excited to have you here with us in our first session, and we cannot wait to see you again in the upcoming weeks for more information as we dive in deep into leishmaniasis. زي ما دايما بنقول أبقوا عافية ونتلاقى إن شاء الله لقدام. مشكورين. تفضل.
شكرا جزيلا. لكن بس شايف زول مهم جدا في التيم الحاضرين هنا، دكتور لؤي صالح. ده الشخصية عظيمة جدا بتساعدنا في موضوع الدواء. شايفين FMOH Disease Control Director BCD BSM. ده الزول المسؤول من الدواء، ده الزول بيساعدنا day and night على أساس إنه نقدر ما يكون في ستوك أوت. ده الزول اللي بيرد على التليفونات بتاعتنا من الفيلد من أي حتة. نتمنى إنه بس نقول له شكرا جزيلا، كل سنة وأنت طيب، ولو اديناه فرصة فتحنا له المايك يكون أحسن. شكرا.
طبعا أكيد إحنا كمان نوصل لهم صوتنا يعني في الشكر حقيقي، شاكرين جدا لمجهوداتهم. Of course they are free to open their mics.
Hello everyone, how are you? Thank you, Dr. Atia, and I will be happy to support always. It is our duty, and we appreciate your always contribution for the different miscellaneous Atia, and for the team, all the team. Thank you all, and we will be here for everything that you need from our supply chain management. And thank you again, and thank you for this fruitful webinar. And thank you, Dr. Mousab and Dr. Atia, and all the participants here. Thank you all.
Thank you so much for all the heroes in the field. الشغل ده ما بيتم بلاكم. We do appreciate all the efforts. إن شاء الله في ميزان حسناتكم لحد ما آخر عيان بتاع VL أو CL أو CML ننتهي من المرض بإذن الله. وهي مجهودات صغيرة لكن كلنا مع بعض بنقدر نوصل لأهدافنا بإذن الله. For those who join us for the first time, we share our links here. All the scientific material would be available on Telegram, YouTube. Join our community in WhatsApp, our LinkedIn, emails. Feel free to reach out at any point, and we're more than happy to help. Any ideas of research are welcomed. Inshallah, Tropical Disease Hospital will be a big research center for all those interested in performing or carrying out researches in the field. Thank you so much. وفتناكم بعافية.
شكرا جزيلا.
شكرا جزيلا.
ورحمة الله وبركاته. إن شاء الله هنشوفكم إن شاء الله على موارد. السلام عليكم.
شكرا جزيلا.
Thank you. Assalamu alaikum.